In this video, we'll talk about the Renin Angiotensin Aldosterone System and how it works to increase blood pressure. We'll also talk about how we can block various steps within this pathway in order to lower blood pressure in patients who are hypertensive. The first step of our pathway is going to take place when renin, a hormone, is released from the juxtaglomerular or JG cells of the kidney. Renin is going to set off our cascade by converting angiotensinogen into angiotensin I. Angiotensinogen is constantly being produced in the liver and released into the bloodstream, but it remains inactive until renin cleaves a piece of it off, which activates it into angiotensin I. Angiotensin I is going to go travel into the bloodstream until it eventually reaches the lungs. So we know the goal of our RAAS pathway is to eventually raise the blood pressure. So it makes sense that renin is going to be released in times that we have low blood pressure, and going along with that also when we have low blood flow to the kidney. This is going to be detected by the baroreceptors that are in the walls of the blood vessels, and it's going to signal to the JG cells to release the renin. A second stimulus for renin release will be the sympathetic nervous system. This is going to occur through norepinephrine directly binding the JG cells through a beta-1 adrenergic receptor. So in times of stress or exercise, this is going to raise blood pressure. The final important trigger for renin release is when the macular densa cells of our distal convoluted tubule recognize that there's low salt in our filtrate. So this either means there's going to be low blood flow to the kidney or there's just less sodium in the blood. In either case, this indicates that there's low blood pressure, and this is going to signal to the JG cells to release renin. So once angiotensinogen is cleaved by renin to form the active angiotensin I, angiotensin I is going to travel in the blood until it eventually reaches the endothelial cells of the lungs. Within these endothelial cells, there's going to be an enzyme known as ACE, or angiotensin converting enzyme, which will convert our angiotensin I into the more active form, angiotensin II. This is a crucial step because on its own, angiotensin I is going to have very minimal physiological effects, whereas once it's converted by ACE into angiotensin II, that's when we'll notice the increased blood pressure that comes from the various downstream effects of angiotensin II. So let's get into what these effects are. There are three main targets that angiotensin II is going to act on, and that's going to be systemic blood vessels, the adrenal glands that sit on top of the kidneys, as well as the central nervous system, where it's going to target the pituitary gland and the hypothalamus, which is right above it. In order to have an effect on these three targets, angiotensin II is going to bind to the AT1 receptor, which stands for angiotensin type 1 receptor. So when it binds this receptor on blood vessels, it's going to cause vasoconstriction. When this occurs in veins, it's going to increase preload to the heart. And when it occurs in arteries, it's going to increase total peripheral resistance. When it binds the AT1 receptor of the adrenal glands, it's going to cause aldosterone release from a specific part of the adrenal glands known as the zona glomerulosa. The effect of aldosterone is going to be primarily sodium retention through acting on the principal cells of the kidney. Remember that water always follows sodium, so when we retain more sodium, we're going to retain more water, which is going to increase our blood volume and eventually increase our blood pressure. And finally, we have our AT1 receptors in the hypothalamus, which is going to cause an increased sensation for thirst, which will ultimately lead to increased blood pressure through increasing our blood volume through the ingestion of water. Angiotensin II is also going to act on our pituitary gland, which releases antidiuretic hormone, or ADH, which promotes water retention in the collecting duct of the nephrons in our kidney. Once again, more water retention leads to increased blood volume and increased blood pressure. So now, knowing how powerful the Renin Angiotensin Aldosterone system can be to raise blood pressure, what can we do if we have a patient that already is hypertensive? Well, in that case, we can inhibit this pathway, which will lead to a decreased blood pressure. So as you can see from this image, there are various steps along the pathway that we can block in order to achieve this common goal of lowering blood pressure. This starts with the Renin Inhibitors, which is the first step in our pathway, and there's only one currently used in practice, and that is Aliskiren. Now, our ACE inhibitors are one of the most commonly used drugs in practice, and these are going to be our prils. It's going to be Captopril, Lisinopril, Ramipril, and Enalapril. Going a little bit further down the pathway, we can block our AT1 receptor, which is going to mediate all the effects of angiotensin II. Our angiotensin II blockers are going to be our sartans, so Losartan and Valsartan. Going even further down the pathway, we can inhibit the actions of aldosterone and ADH. Our aldosterone receptor antagonists are going to be spironolactone and eplerenone. Our ADH receptor antagonists are going to be our Vaptans, Conivaptan, and Tolvaptan. Using what we just learned, let's answer this question. Which drug works to lower blood pressure through inhibiting the conversion of angiotensin I to angiotensin II? So all of the drugs we just learned about are going to lower blood pressure, but to answer this question, we have to understand which drug class has a mechanism of action that's going to inhibit the conversion of angiotensin I to II. So this is going to be our ACE inhibitors. So now we just have to remember which of these is our ACE inhibitor. Well, our Conivaptan is going to be one of our ADH receptor antagonists, so that's not an ACE inhibitor. Aliskiren is a renin inhibitor, and Losartan is going to be our angiotensin II receptor blocker. So we're left with Captopril, which is our ACE inhibitor. Last question. In which of these locations are AT1 receptors not found? So in other words, where does angiotensin II not have a major effect? So we know it's going to constrict our blood vessels, so it can't be A. We know it's going to have an effect on the adrenal glands in order to release aldosterone. And we also know it's going to act on the pituitary and the hypothalamus in the brain to increase thirst and to release ADH. So the correct answer is B, the liver, where angiotensin II does not have a major effect.